Dr. Edgerton, you're a pioneer, a trailblazer, an outlier, an innovator, an educator, a father, a grandfather, and a great-grandfather. These are all words that I use to describe you. When and where were you born?
I was born in Atlanta, Georgia, in 1921. My father was also a Hopkins graduate and a doctor in Atlanta, and he had moved there after World War I and opened his practice. So I grew up in Atlanta and ultimately went to Emory University because of that. I had met my wife while I was a medical student at Johns Hopkins. She had taken a job in the hematology department, and we had been dating whenever we found the time. When I started my internship, it was at Barnes Hospital in St. Louis. We were not allowed, of course, to be married in those days. And during that year, while I was engaged to Pat, she went out to Salt Lake City to continue her work in hematology with the team at Hopkins who had moved to Salt Lake. I knew full well there were two young men in that hematology program who were very interested in Pat, and I was uneasy about leaving her unattending for a full year. In the middle of the year, I managed to get a few days off and took a train out to Salt Lake City to see if I could reestablish my credentials. Fortunately, I was able to do so, and we continued the engagement, and 2 days after I finished my residency year, we got married, and 1 day later I entered the military at Camp Carlisle in Pennsylvania. I had this wonderful training experience during the war at the Valley Forge Hospital. And I came back to Hopkins after the war ended, and I wanted to complete my general surgery residency training. And I found myself in the evenings sneaking back to see what was happening to the plastic surgery patients that some of the other surgeons were taking care of at that time. And I realized I was really more interested in those cases. It was a marvelous experience. I don't think I could imagine a greater training program than the treatment of those massive injuries that were being flown in from all theaters of the war.
Well, I want to quote Sir Isaac Newton. If I can see farther, it's because I'm standing on the shoulders of giants. Tell us just a little bit about John Stage Davis, and also, if you would, about Harry Muller, who was the previous head of the Department of Surgery here that was farsighted enough to bring you here, and why we're sitting here.
Yes. Well, of course, Stage Davis, as everyone knows, was America's first totally qualified plastic surgeon. And while I was a medical student at Johns Hopkins, he was still active, and I had the opportunity on more than one occasion to assist him in the operating room while he was doing various operations. I remember being amazed to see him with a small baby in his lap as he was trying to do a cleft lip, and this tall gentleman would take the needle holder in his hand, and as he would approach the baby, the hand would be shaking very intensively, and when he got right to the point of putting the needle in, it got perfectly still. And he had this intention tremor, but it never seemed to affect the way he handled the needle. It was an inspiration to watch how gently he handled all of the tissues. I was lucky when I went to St. Louis to have a somewhat similar experience with the other great pioneer in American plastic surgery, Villery Blair. And having an opportunity to watch and help Dr. Blair with his efforts to reconstruct the human ear using the ear cartilage of the baby's mother to create the ear in the new child. Those were fascinating times.
And Dr. Harry Muller.
Dr. Muller, a wonderful friend. He was a colleague of mine after the war in the general surgery residency at Johns Hopkins. I returned to Hopkins after leaving Valley Forge. And interestingly, at one point, he was interested in becoming a plastic surgeon, and we discussed it at some length, but he had already gone through Dr. Blaylock's cardiac surgery program, which was in great demand in those days. And he finally decided to be a cardiac surgeon instead of a plastic surgeon. And his career was outstanding. He went out to California, he pioneered mitral valve surgery, and ultimately was invited back to the University of Virginia to be its chairman of surgery. Well, that turned out to be a blessing to me because some years later, Dr. Muller was interested in getting a plastic surgery program going at Virginia. In the course of the conversation, he just casually said, "Why don't you come and help me out?" And I said, "Harry, I'm not interested unless Virginia would be willing to give me a department status, which I think plastic surgery needs, and which I had been unable to obtain at Hopkins." He said, "Well, it's not in my power to grant that, but I'll call you back." And 2 days later he did, and he said, "If you come to Virginia, you can have full department status." And that was a kind of a dream come true, and is the reason I am in Charlottesville.
And they actually, and just to catch some people up, is that everything was divisions of plastic surgery. So ultimately, plastic surgeons were responsible to the general surgery department, didn't have autonomy because there was a division of plastic surgery here before you came, but
That's
you
correct.
took the big step and had your own funding. You brought Dr. Knorr with you in the Department of Psychiatry.
That's correct.
And you had the only appointment, is it the only appointment that's ever been for a psychiatrist in the Department of Plastic Surgery?
I think that probably is still true today.
In your opinion, what has been the most important innovation in our specialty?
Well, in my lifetime, the biggest change came when we developed microsurgery techniques. The ability to repair small blood vessels and small nerves opened up wonderful opportunities. During the wartime at Valley Forge, for example, we learned that we could move large blocks of tissue, skin and fat, to the facial area with good results, but we usually had to move those tissues in stages, attach them to the wrist, to move the wrist then to the face. It was laborious. Mm-hmm. Nowadays, those procedures can be performed in a single operation, greatly reducing the cost and indeed improving the quality of the reconstructions. I think that has really transformed a part of plastic surgery.
In your opinion, what is the greatest mistake our specialty has made?
Well, I've thought about that over the years. I believe many years ago I started trying to suggest to some of our leaders that we find a way to combine the specialties of plastic surgery, otolaryngology, and maxillofacial surgery. there is a tremendous overlap in the anatomical regions, mainly around the head and neck, that all of these specialties function at. And as a result, in every medical center, there is a constant competition for the clinical material and the teaching material when these patients arrive at a hospital. Depending on which clinic they happen to go to first, they may get an entirely different treatment because there is rarely a coordinated plan among these programs for the final choice. If these programs were ever to get together and unite, and they are moving, I think, in that direction, because I now see a number of young men and women who are taking board-certified training in more than one of these specialties. But if the medical schools would allow these different specialties to merge, not only would the quality of patient care improve, but the influence of that program, which would be enormous, would be increased in the medical school itself.
What do you feel is your greatest professional accomplishment?
I've thought of that from time to time, and really there are two categories, of course. One is in teaching. I have had great satisfaction, not only in working with the medical students and the residents, but in seeing many of these young surgeons go to different parts of the country and head up similar teaching programs. That's been very satisfying. On the clinical level, from a personal standpoint, there are two or three areas that I think I've been able to make a contribution. One of these is in helping to get plastic surgery established in the academic centers around the country. It used to be a specialty with very little impact in the medical school curriculum. Thanks to the effort, not just of myself, but of several others. I'm thinking of people like Bob McCormick from Rochester. Nowadays, medical schools, medical students get exposed to plastic surgery as an opportunity for a career in teaching. From a clinical operative standpoint, the introduction of immediate reconstruction for patients undergoing major surgery for head and neck cancer. That initiative really grew out of Valley Forge. I had learned at Valley Forge that many of these major deformities of the head and neck could be repaired quickly. And when I got back to Hopkins, I saw that some of the patients after cancer surgery could in a similar way be reconstructed at the same time that the cancer was being removed. We undertook and developed some methods for doing that, reported it, and I'm pleased to see that in most cancer programs now, immediate reconstruction is being performed after head and neck cancer operations. I got early into craniofacial surgery, thanks really to the accidental appearance of a little girl from Tennessee on whom we did a procedure, not knowing, for example, that moving her eyes from the side of her head to the front of her head would or would not damage the optic nerves. Interestingly, when we told the parents, we were not sure whether that danger would develop. They were unable to make a decision about permission for the surgery. And this little girl, 8 years old, heard the whole discussion and spoke up and said, "Mama, Daddy, please let them operate. I don't want to live like this." Can you imagine such courage from a child? Another area that developed, again, almost by was this question of transsexual surgery. At the time, no one in this country would do transsexual surgery, and the patients had gravitated by word of mouth to Casablanca, where a Dr. Burrow was doing some type of transsexual surgery. And after the operations, the patients were taken back to the airport and given their passports and sent home. Some of them had had not very good surgery and had fistulas and other problems, and a number of them landed at Johns Hopkins for further reconstruction. And we undertook repairs of some of these problems. The surgery had not been really very well done. But I was impressed that not any of these patients, even those with bad surgical results, blamed the doctor that had caused the problem. They were still grateful to him for having at least initiated the operations and the change. That got us to thinking, and we began to see some of these patients in a clinic, an interdisciplinary clinic. We had gynecologists, a urologist, psychiatrist, the endocrinologist, the full team, and we very carefully began to process some of these patients to see if indeed surgery made sense. The patients were selected fairly carefully. If they were on drugs, for example, we tended to stay away from them. And as time went by and these patients began to return, we found that they were extremely grateful for the surgery. Front page of the New York Times, there was a program about Hopkins doing transsexual surgery. In a period of, I think, 2 weeks, we got about 3,000 letters from all over America of transsexual patients, handwritten letters, 8-10 pages long, begging for surgery. One of my big disappointments, maybe one of my main professional disappointments, is that although some American surgeons took up the treatment of the transsexual patient, very few did. And even today, it's hard for American patients to find surgeons in this country to carry out their surgery.
Your greatest joy, it can be professional or personal.
Well, I mentioned earlier the joy of teaching residents, and of course, every day, starting the day, scrubbing your hands, and then going into the operating room, knowing you have a chance to really improve the self-image of that particular patient. That made every day going home from the hospital a very happy feeling. I've got 4 children, 11 grandchildren, 4 great-grandchildren, and 3 more great-grandchildren due within the next 2 months. Retirement is something plastic surgeons struggle with, and I think I've talked to a number of them about it, including my own son, who is a plastic surgeon. The profession is so satisfying that if the surgeon is healthy and continuing to get good results, it's hard for him to put down the scalpel. On the other hand, there are other things in life that individuals, plastic surgeons, perhaps would want to avail themselves of. Travel, reading, other fields of interest, painting, more time with family. These are things that are available in retirement that are hard to find while working full-time. I worked surgically until I was 73. As I look back on it, I wish maybe I had retired a little sooner. In part because my wife developed Alzheimer's not long after I retired, and we did not get to do some of the things, travel, etc., that I was planning to do when I did retire. So I would urge plastic surgeons to give thought to some of the good things about retirement.
In 1997, you gave the honorary address to the Southeastern Society. It was the Upchurch Lecture, and they asked you as an honor to speak there on whatever you want. And it's in the Annals of Surgery, Annals of Plastic Surgery, excuse me, volume 38, 1997. It's called Plastic Surgery, the Rainbow Profession. Quote, "Today I would like to suggest that plastic surgery is a rainbow profession. By this, I mean our work has many colors. Our patients include every group. Their deformities arise from any cause, including congenital, traumatic, infections, neoplastic, metabolic, or just the natural process of aging. These many colors of the patient's rainbow add spice and variety to our professional lives. We are very lucky." And if you would read the last paragraph.
But there is something more marvelous. Each week, every day, each month, plastic surgeons repeatedly witness the black magic of our specialty. Namely, what is this black magic? It's the transformation of personality and greater increase in self-confidence and in the perception of the self-image that must be improved. Not that the surgeons or others are of others of the inhibiting influence of the perceived deformity somehow has been erased by the scalpel, the scissors, and the sutures. What a magnificent responsibility for a surgeon to have. I think I was born and got into plastic surgery at one of the most exciting periods of the development of the field, largely springing out of World War II. From that time forward, for the next 50 years, the field of plastic surgery has just grown enormously. It's been very exciting to see the new developments. I just feel very lucky to have lived in the period when that occurred.